So this is a case of posterior polar cataract. So be it a novice surgeon or an experienced one, this is going to give chills during surgery. A proper preoperative evaluation in the slit lamp is very important in these cases. You have to look out for signs of posterior capsular dehiscence like the fishtailing or the elevation of the posterior polar component. Here there are no such signs. So paracentesis is made, and with the help of a 2.2 mm keratome, the primary incision is made. Then intracameral adrenaline is injected into the eye to attain maximum mydriasis. Once the pupil is dilated to its maximum, intracameral tryphan blue is injected to stain the anterior lens capsule. It is very important to stain the capsule in such cases. Though there is a good red glow, it is very important because at the event of a posterior capsular tear, if we want to do a reverse optic capture or placing the IOL in the sulcus, all that will be very helpful when we have a stained rhexis margin. Viscoelastic is injected into the eye, and with the help of a cystitome, capsulorhexis is initiated. The size of the capsulorhexis is very important when we are operating on a posterior polar cataract. Try to keep it below 6 mm so as when you have a PC tear, you can place a 3-piece intraocular lens in the sulcus and then do a reverse optic capture. So once the rhexis is completed, with the help of a Kydro cannula, while minimally injecting BSS between the capsule and the cortex, a little bit of cleaving is done on both sides so as to separate all the adhesions between the capsule and the cortex. So once this separation is done, starting from the periphery, hydrodelineation is done. So I prefer to do multiple hydrodelineations starting from the periphery to the center. Around 4 delineations are done in this patient. You can see almost 4 rings here. So once the delineation is done, the anterior chamber is again filled with viscoelastic. Here I prefer not to use a chopper in such cases. Instead, I use a Sinski's hook and go in with my phaco probe in epinucleus mode where all my parameters are less. Starting from the center, from the endonucleus, gently layer by layer, the nuclear material is emulsified with almost no phaco power. So you start from the center and go to the periphery. So this is one common problem that is going to be there when we are operating on a posterior polar cataract, removing the subincisional epinucleus and cortex, because we have not done any cleaving or separation or hydro in this case. So at this point, it is very important not to collapse the anterior chamber. Inject viscoelastic and then withdraw your phaco probe when you are in foot pedal 0. Gently do a visco dissection on all sides. So this will help in maintaining the anterior chamber and not collapsing it, and at the same time your cortex and epinucleus will be separated from the posterior capsule. So with irrigation aspiration probe, the cortex and epinucleus is gently separated from the periphery on all sides. You do not aspirate the cortex and epinucleus in this case completely. You separate it and bunch it all together in the center. So the main reason behind doing this is, even if you are going to have a posterior capsular tear in this case, all your cortex and epinucleus is free floating and it is all together and not in multiple pieces. So when it is together, it is very easier for us to aspirate it. So once all the separation is done, once it is all bunched up in the center, gently aspirate the cortex and epinucleus. So I prefer to keep a linear setting while I am doing this step so as to have more control when I am removing the cortex. Luckily in this patient there was no posterior capsular dehiscence. So all those dark spots on the posterior capsule or the fibrous posterior capsular areas, it is very important to avoid doing PC polishing in such cases. Those fibrous areas are very fragile, so with a little bit of pressure they can give way. So it is very important to do a delicate IOL injection and visco wash in this patient. Since it is a 2.2 millimeter incision, a wound-assisted IOL injection is done where the leading haptic is directed into the bag and the trailing haptic is gently tucked inside the bag. After positioning the IOL properly, visco wash is being done. So as I mentioned earlier, it is very important to do a very careful and delicate visco wash and IOL placement in these cases. A little bit of rough handling can result in a spontaneous posterior capsular tear, like in this case. So when you see this, do not panic and do not remove your IA probe instantly, which can cause extension of the posterior capsular tear and vitreous disturbance also. Here the probe is held inside, and at the same time, using the left hand, BSS is used to hydrate the side port, and gently the IA probe is withdrawn. So the question is, what do we do now? Do we explant or leave the IOL as such? As soon as the IA probe is withdrawn, the primary incision is also hydrated. So it's very important to observe the status of the intraocular lens while hydrating. If you see any rotation of the intraocular lens while hydrating, it means the IOL is not going to be stable inside the eye. You will have to plan an IOL explantation or proper positioning of the haptics of the IOL. But in this case, as the intraocular lens is very stable, we are not going to intervene. Intracameral moxifloxacin is gently injected and the anterior chamber is formed. To summarize, we are operating on a posterior polar cataract. It is very important to have proper mydriasis, proper capsular staining, an adequate rhexis size of less than 6 mm. Always do multiple hydrodelineations. Do not aspirate cortex by the clock hour. Instead, separate them from the periphery, bunch them in the center, and then aspirate. Never polish the posterior capsule. Look out for fibrous spots on the posterior capsule. Avoid aggressive maneuvering during surgery. At the event of a PCR, do not panic and do not remove your phaco probe or IA probe instantly without forming the anterior chamber. And most importantly, do not collapse or overfill the anterior chamber at any point of surgery.